It is my pleasure and honor this night to have this session dedicated for vascular access. Today we have 4 cases that will be presented by one of the very active specialist nephrologists at Urology and Nephrology Center, Mansoura, Egypt. And it's my pleasure today to work in collaboration with the Kidney Academy, and we have Trace with us, and we are waiting the rest of the crew to join us. And we are waiting Dr. Ahmed Sheashaa will speak after in the second part about decision making in dialysis access. We consider dialysis access is the line, not line for dialysis, but it's line for life. This is Dr. Ahmed Sheashaa. He is a graduate of University of Cairo School of Medicine, and was trained in internal medicine in the United States. He finds his way through different centers. He is qualified and certified from the American Board of Internal Medicine, American Board of Nephrology, American Hypertension Specialists, American Board of Diagnostic and Interventional Nephrology. And this is the specialty that we would like to advocate in Egypt and Arab world, to have nephrologists indulged in all interventional activities. Also, I'd like to welcome Professor Dalia Zaki Dawood. She is the clinical assistant professor of University of California, intervention nephrologist, nephrology associate member group, a member of education committee from the American Society of Diagnostic and Intervention Nephrology. So we will be delighted to have Dr. Dalia with us. I appreciate the collaboration with the Kidney Academy, and I think this is a very good template for CME education. And the special interest of the site is dialysis and vascular access. So I am appreciating their announcement about this meeting at their site. I'd like to stop here, leaving the mic to Dr. Ahmed Yahia to start his presentation. Dr. Ahmed Yahia.
Thank you, Dr. Hussein, for providing me this chance, and thank you for Dr. Dalia. Today, I will talk shortly about 4 cases of hemodialysis patients with vascular access difficulties. A 39-year-old end-stage renal disease man on chronic hemodialysis since 1997, secondary to posterior urethral valve. His graft failure due to intraoperative graft artery thrombosis in 1999. The patient is non-ischemic heart disease since 2007, and he underwent coronary angiography and was treated medically by aspirin and clopidogrel. The patient has good systolic function, only mild mitral regurg. He underwent posterior urethral valve fulguration twice, bilateral uretrovesical reimplantation, left nephroureterectomy, right renal allotransplantation, and graft nephrectomy in 1999. The patient first received hemodialysis from left radiocephalic AV fistula. Then he received hemodialysis from left brachiocephalic AV fistula and then brachiobasilic AV fistula. After failure of the previous 3 AV fistula, he received the dialysis from right radiocephalic AV fistula. Then right brachiocephalic AV fistula. Each fistula was closed by thrombus after repeated attacks of intradialytic asymptomatic low blood pressure. Patient baseline blood pressure was 90/50, but it was asymptomatic. The patient was maintained on alpha agonist, and multiple attempts were performed to avoid intradialytic hypotension, like modulation of dry body weight, giving fluorocortisone or midodrine. Thrombophilia screen was negative. ACTH stimulation test was normal. After that, the patient received hemodialysis from right arm straight graft, which lasted for 5 months. Unfortunately, the arm graft was closed by a thrombus due to intraoperative hypotension while he was operated for fractured neck of femur. Internal jugular vein permicast and the femoral permicast were inserted after that, but the catheters were complicated by repeated attacks of castor-related bloodstream infection. So the patient received hemodialysis from axillo-axillary graft AV fistula, which was performed in November 2018, and it is functioning till now. Here is the site of needle insertion with space nearly 10 centimeter in between. Data of the patient reflecting hemodialysis adequacy were collected and compared during the periods of AV fistula, AV graft, axillo-axillary graft. There was no statistically significant difference regarding pre-dialysis serum creatinine, PUN, calcium phosphorus, bicarbonate, albumin, hemoglobin, and single-pooled KTV, indicating that the patient received adequate hemodialysis from each of them. Second case is a 42-year-old end-stage kidney disease patient on chronic hemodialysis in the period between 2005 and 2007, secondary to hypertensive nephropathy. He received right renal allotransplantation in 2007, but the graft failed in 2009. The patient is HCV positive, antibody positive, PCR negative after direct-acting antiviral. The patient received right renal allotransplantation in 2007, and he underwent multiple hemodialysis vascular access creation. The patient first received hemodialysis from left brachiocephalic AV fistula, then right brachiocephalic AV fistula, left brachiobasilic AV fistula, and right brachiobasilic AV fistula. After all these axes, he received hemodialysis from axillo-axillary AV fistula, which lasted for 2 years. The main problem in this patient was the large intradialytic weight gain, 6 to 9 kilograms between each session, with arterial filtration rate 750 milli per hour. So the patient was complicated by intradialytic hypotension. Frequent prolonged hemodialysis sessions, 5 per week, 5 to 6 hours each, was performed to avoid intradialytic hypotension. Also, dialysate sodium was adjusted to achieve serum sodium levels around 135 milliequivalent per liter. After failure of multiple AV fistula, we proceeded for right great saphenous common femoral AV fistula, which was performed in January 2019, and it is functioning till now, and the patient is maintained on warfarin. In April 2020, the fistula was poor functioning. Venography revealed 2 stenotic segments. Angioplasty and balloon dilatation were performed, and the fistula became well functioning again. Here we can notice the flow of dye without any stenotic segments. In July 2020, the fistula was closed by thrombus. Angioplasty and thrombectomy and balloon dilatation were performed by vascular surgeon, and the fistula now is well functioning. The third case, a 40-year-old end-stage kidney disease on a man on chronic hemodialysis, the period between June 2010 and October 2010. The original kidney disease was unknown. The patient received 2 kidney transplants, the first in the period between 2010 and 2014, and the second in 2015. The patient returned to hemodialysis after the second transplanted kidney in 2015. The patient received right renal allotransplantation in 2010, left renal allotransplantation in March 2015. He underwent left graft nephrectomy in April 2015, Tinkoff caster insertion in July 2015, femoral AV fistula creation in October 2015. In 2010, the patient received hemodialysis from temporary left internal jugular catheter for 3 months. Then he received first kidney transplantation. After failure of the first renal transplantation, he received hemodialysis from permanent left internal jugular catheter for 6 months. Then he received the second renal transplantation. Unfortunately, the second transplanted kidney failed early post-transplant due to antibody-mediated rejection with elevated donor-specific anti-HLA antibodies titer. AV fistula creation in both upper limbs was difficult due to presence of unsuitable veins in both arms by physical examination and poor Doppler indices, small vein diameters, and poor distensibility. Internal jugular catheter insertion in both sides failed, so CT angiography on neck vessels were performed. CT angiography revealed thrombosed left internal jugular vein and attenuation at the lower end of right internal jugular vein. This is the thrombus in the left internal jugular vein, and here's the attenuation in the lower end of the right internal jugular vein. Venography of the right internal jugular vein showed narrowing at the confluence of both brachiocephalic veins. So the decision was for peritoneal dialysis. Tinkoff catheter was inserted in December 2015, and the peritoneal dialysis was initiated. However, the patient referred again with signs of inadequate dialysis 3 months later, volume overload, hyperkalemia, and uremic manifestation. Left temporary catheter was inserted, and the patient was shifted to hemodialysis, but the left femoral catheter was malfunctioning. So we have to search for another site for AV fistula. AV fistula between the right great saphenous vein and the superficial femoral arterial superficial femoral artery was done in June 2016, and it is functioning till now well. The patient is maintained on warfarin with target INR 2 to 2.5. Our last case is a 44-year-old end-stage kidney disease man on chronic hemodialysis since July 2012. His original kidney disease is unknown. The patient first received hemodialysis from left proximal AV fistula. 8 months later, there was aneurysmal dilatation of the AV fistula and left arm swelling. Conventional venography showed occlusion of the left brachiocephalic vein with reflux of the dye through the internal jugular vein. This filling due to the multiple collaterals. So stent was put on the left side. Trial to partially ligate the aneurysm of the left AV fistula failed. So right proximal AV fistula was created. The right AV fistula remained functional for 18 months. The patient suffered from swelling and hotness in the right arm. CT of the neck vessels showed partially thrombosed lower end of the internal jugular, proximal end of the subclavian, brachiocephalic, and the upper distal portion of the superior vena cava. This is the venous phase, and this is the arterial phase. And the decision after the radiography was to close the right AV fistula. As the patient was planned to receive kidney transplantation, right femoral permecatheter insertion was avoided. The plan was for left femoral permecatheter, which was inserted, but actually it was malfunctioning. So the last decision was for translumbar IVC catheter insertion. Here we can see the needle locate the IVC, and the location was confirmed by injection of the dye. Then we inserted the guide wire, then followed by a contrast again. Then the sheaths and the catheter were inserted. Recommendation to the nurses were given regarding the importance of this axis being the last available one. The catheter was locked using a Torolock HIP 500 in complete sterile environment. The patient noticed the thrill at the site of the previously removed femoral catheter. CT angiography of lower limb revealed AV fistula between the femoral vessels, iatrogenic mostly, sure immature iatrogenic. Here is early filling of the venous phase, while there was no emptying of the arterial phase. Here is the site of the AV fistula. Closure of left femoral AV fistula was done. Insertion of hook catheter from the other side, from the right in the iliac vessels, to reach the fistula in the left side. Dye and contrast was injected to allocate the AV fistula. After that, the stent was put. Injection of the contrast after the stent was put revealed closure of the AV fistula, no filling of the vein in the arterial phase. Regarding IVC catheter, it is indicated in hemodialysis after failure of conventional vascular axis and thrombosis of superior vena cava. It can be inserted either transhepatic or translumbar. In transhepatic approach, we have to allocate hepatic vein and enter through the hepatic vein to reach the anterior caval junction. In the translumbar approach, we allocate from the lumbar region the IVC just below the renal hilum to avoid injury of renal vessels. Then we insert the needle, and the location of the IVC, the AVC, the location of the needle is confirmed by contrast injection, followed by a guide wire. Then the sheath and the catheter were inserted. Then tunnel can be made, or the tunnel is made from medial to lateral. These pictures were imported from the lecture of our eminent Professor Tariq Diasti, Professor of Interventional Radiology in the Mansoura Urology and Nephrology Center. Here we can localize the IVC catheter by radiology. Here is the tip of the catheter at the cavo-atrial junction. Take-home message. Well-functioning vascular access is the mainstay for adequate hemodialysis. There are three main types of vascular access: arteriovenous fistula, arteriovenous graft, and central venous catheter. Each of them could deliver adequate dialysis if it is well-functioning. Protection of vascular access against hemorrhage, thrombosis, and infection is the responsibility of the patient, nurse, and the physicians. Before AV fistula creation, upper limb physical examination is important, but it still gives limited data. Doppler ultrasound predicts the future of the suggested AV fistula, thus protecting against useless AV fistula creation. Efforts should be done by nephrologists to avoid intradialytic hypotension. Correctable causes of intradialytic hypotension should be treated. Cardiovascular assessment of the dialysis patients may help in avoiding intradialytic hypotension. Baseline low blood pressure is associated with poor AV fistula outcome, even if it was asymptomatic. Patient education about the risk of intradialytic weight gain on the axis may prolong the axis survival. Axillo-axillary AV grafts offers good option for saving life of hemodialysis patients with failed multiple AV fistula. Adequacy of hemodialysis was comparable on using AV fistula, AV arm graft, axillo-axillary graft. Lower limb AV fistula remains the important axis should be taken in consideration as a life-saving axis. IVC catheter is a good solution after failure of conventional methods. Thank you.
Thank you very much, Dr. Ahmed Yahia, for this case series presentation. Actually, they are very wonderful cases that reflect the experience here at the center. And as a commentary, until we have Dr. Mohammed Sheashaa, first we should take care of fistula. In the past years, we are taught from professors of medicine that we should take care of the foot, diabetic foot, like the caring of heart in diabetic patient. Here in nephrology, we should take care of the fistula, early creation, saving fistula, and there are many articles about the fistula, and the Advanced Kidney Journal, the last issue was dedicated for fistula. And I like to postpone my comments until I hear from professors and colleagues their comments. I'd like to start with Professor Riyad Saeed. Dr. Riyad, what are your comments, please?
Well, I think, Masa al-Khair.
Yeah, Sahna.
I think what really we have, as you mentioned, it's the lifeline for our patient is the vascular axis, is the V fistula. Early creation is the note. Don't, try to use AV fistula as early, just postpone it until it's mature. Give it enough time for maturity. Premature use of the AV fistula, that's basically the first line of failing fistula. Secondly, as you mentioned, all these patients, seems to be 3 of them at least, I recall, they have kidney transplant, failed kidney transplant. If there is any really correlation between this and what they have, what they are on in. I noticed 3 patients, second kidney transplant. Both of them, first, second kidney transplant. I don't know if there is any coagulable status in those patients. One of them, I hear that all the workup for thrombophilia was done, i.e. protein S, protein C, and antithrombin 3, all that really has been done for the patient, and it was negative. The last resort, as I heard from my colleague, is the IVC catheter. I think we have used it here twice or 3 times for patients who came to us from the West Bank, where they really exhausted all the vascular axes. And that's the only experience I recall with a couple of patients who came in with this catheter. The femoral sites, always we try to save it to the end. Try to avoid it. It's not a clean area. It's a dirty area. More complication with thromboembolization, infection, and others. So that's really the comments that I have.
Thank you very much, Professor Riyad. Professor Faissal.
Thank you.
Your comments, please.
It's excellent 4 cases, and I actually have a few comments, especially with the axillary AV fistula, which could precipitate heart failure. I don't know that they have experience for that or not, because if you reach nearby the heart, you may get heart failure. The other things is about, again, the patients who had hypotension. It is known that such patients usually, if they got hypotension during dialysis, the outcome of the renal transplant also is poor, because around 60 to 20% of those patients can develop thrombosis and graft failure. And this is one of the things which we should take care usually with those patients which are hypotensive during dialysis if we think about transplantation with them. And again, if you look for these 4 cases, myself, I have experience in nephrology for more than 40 years now, and axillary fistula, I never saw one femoral I saw, IVC I saw, but axillary I never saw one of those fistulas, and I hope that I can see one of those in a very difficult case and difficult situation, because from the picture it seems to be a good fistula, but I don't know about the heart. And again, about the steel phenomena in such difficult cases, or which you got with with thrombosis. Many of them got thrombosed and stenosis. I don't know how is the periphery with those patients. Thank you. It's excellent, excellent 4 cases.
Thank you very much, Professor Faissal, for your comments. And I agree with you that the proximal, the site of the fistula, the high the burden on the heart. This is why we evaluate the fistula flow by Doppler, and even for the fistula, for the upper arm fistula. And if we find the flow is very high, hyperdynamic, that can precipitate heart failure, even we, in collaboration with vascular surgeon, we can do some plastic surgery to narrow the lumen of the fistula to reduce the flow, because this may be hazardous for the heart. This reminds me by the issue of closing fistula after successful transplantation. If we have patients after the success of transplantation, we evaluate the site of fistula and its burden on the heart. If we find hyperdynamic fistula, proximal fistula, we may close the fistula after at least 6 months of adequate graft function. This is a point. We have an experience here and we published this article since 15 years, spontaneous closure of AV fistula at the time of transplantation. And we got the lesson. The fistula is associated with high output, increased cardiac output, increased cardiac index, but ejection fraction was good in our series. But if we have borderline heart or heart failure, I think this fistula is a real problem to put in mind. I think this is the ugly face of the fistula, but the good face, it is a line for life. That's why we should take care of the fistula. I have many comments to be added, but I prefer to hear from our guests and audience. If anyone of professor likes to comment, please raise your hand, and I'm going to unmute you, please. First, unmute yourself, Dr. Yasser. Dr. Yasser Al-Mula.
Excellent talk. Many thanks, as usual. Can I just ask a few questions?
Yes.
Do you have any experience with using hairograph? That's one question. The other question is, we have now increasing number of patients that were starting on dialysis at an advanced age. So for example, today I had to place a line for a patient who is 97-year-old, but the functional status is very reasonable. So, you know, I think we're going to face this problem more and more. So my only question to the presenter is, number one, do you have any experience with the hairograph? And I want to mention, you mentioned that the IVC catheter, translumbar or transhepatic, we have a lot of patients who are using this type of catheter. And we also have a total of 7 patients who got arterial tesio, arterial tunnel line, done by the cardiothoracic surgeon in theater under GA, where they place the catheter directly into the atrium of the heart. And it's done through the sternum, like, you know, the same way that they do the bypass, because even their lumbar, translumbar and transhepatic catheter placement into the IVC didn't work. In terms of the femoral tunnel line, can I just ask what length of the tunnel line are you using? Because we used to have a lot of femoral tunnel line at the moment, right and left, though I fully agree with Professor Riyad about that. It should be always the last option. It's not a clean area. Risk of infection is very high. But what we face is, if we put a catheter that's relatively short, then the risk of malfunctioning in the near future is very high. And that's why we started using a 40 centimeter catheter when we do the femoral tunnel line. So you can argue that the tip is already in the IVC when you use a 40 centimeter for someone who is relatively short. This is in addition to what's already commented on by Professor Riyad and Faissal Shaheen, and I'm sure that Prof. Sheashaa will add a lot on that as well. Thank you so much. And last question as well. For this patient do you have venoplasty for them, those with SVC narrowing obstruction? Because what we do when we face this is we go with the IR, with the radiologist, and they do venoplasty. So we can still use, like, the upper veins catheter again twice or 3 times. And we also have a program for those who are having clotting of the fistula, and we do declotting for them. Is rather than waiting for another clot, we do screening for them by fistulogram every 3 months, just to see what's the status of that. Thank you so much.
Excuse me, Dr. Yasser, please keep with us. Regarding your activity, as nephrologist, you do all these, so you have an active interventional nephrology activity at your center?
So if you have 2 minutes for me to answer this.
Yes.
I used in the past to work in Muscat, Sultan Qaboos University Hospital, and sadly all the interventional procedures are done by the radiologist. So the biopsy and tunnel line are all done by the radiologist. The nephrologist, they only do vascath. I went to Republic of Ireland, where I did spend some of my training there, and again it's the same as in Muscat. And then I came to the UK. So in UK, 80% of the unit are doing all the procedures by the nephrologist. So I do tunnel line. So I do, for example, myself, right internal jugular blindly. I do left internal jugular under fluoroscopy. I do femoral blindly, tunnel line, and I do translumbar and transhepatic under fluoroscopy guidance. Sometimes if I struggle, so we have different equipment, but if I struggle with the transhepatic or the transjugular, we call the IR, so we do it a shared procedure, both of us to do the procedure. In terms of the fistulogram, it's done all by the IR, and declotting is done by IR. IR means the interventional radiology. So we don't have, the surgeon rule is only to create the fistula. And we got a couple of nephrologists who create the fistula themselves.
So I think this is a very nice experience that we like to advocate here in our region and our country, because even at Urology and Nephrology Center, all interventional activities done by radiologists. So
can I just ask Prof. Sheashaa, who does the tunnel line?
The radiologists, not us.
Okay, even the neck one.
Yes,
okay.
And the surgery. And so the vascular surgeon and the interventional radiologist did all these activities. But currently, we insert internal jugular, femoral, and all these lines under ultrasound guidance.
Okay.
Because in the past, we insert them blindly. And I think after shifting to ultrasound guided insertion, I think complications becomes down. And this
so
is
just
very nice.
Correct. And this is very important for the records. When I say I do the right internal jugular and the both femoral blindly, I mean with ultrasound. So that's what I meant with the blindly. But
Yes.
when I said left internal jugular or the transhepatic, translumbar, under fluoroscopy. But when I say blindly, definitely that's with the ultrasound, because we use ultrasound even for a cannula nowadays.
Very nice. And I would like to comment on the old senior patient, 90 plus, and there is a very nice report from United States Renal Data System about the fistula in elderly. Yes, the fistula, the older the age, the more the prediction of the fistula closure and thrombosis. But we shouldn't deprive the senior patients from doing the fistula, because fistula, I think it is the best vascular access, but it's not the best in all situations. So we should individualize our approach. And I think if we have Dr. Sheashaa with us.
Just one comment to Professor Hussein. The only problem here, the government pay the hospital based on the type of access. So for example, if I have 2 patients, one patient is using a fistula and one patient is using a line, the government will pay the hospital double for the patient with a fistula. So we got 200 quid per session if the session is done through a fistula, and we got 100 quid if the session is per session if it is done through a tunnel line. So that's one of the major things. If anyone from Egypt is interested in interventional nephrology and they want to do tunnel procedures, they want to do fistulogram, and they want to do more IR, you can kindly put them in touch with me, and I'm more than happy to arrange for them to have a 1-year paid job at the Edinburghs to facilitate this for them.
This
and I'm
is very generous.
Online.
This is a very generous invitation from Dr. Yasser. I like it. And just a simple sentence, the fistula is the best at large, but may not be the best on an individual basis. This is why we should individualize our management. If we have an older patient, an older age patient with multiple vascular problems peripheral vascular disease, coronary artery disease, shorten the life expectancy, I think the best is not fistula, the best will be catheter. And at large, we don't like catheter, but we are obliged in some cases to insert catheter permacath for doing dialysis for certain patients. And we should fight temporary catheter for incident dialysis, because this is a great problem in many areas in the world, to start dialysis through even temporary catheter, with the risk of infection, admission, and mortality. Regarding ultrasound, the BOCUS, thermo-BOCUS, is point of care ultrasound. I am advocator of BOCUS for renal ultrasound in general. The echocardiogram, just one look at the valves while it is opening and closing, everything is fine. From systolic function, the muscle mass, calcification of the valves, presence of effusion, I can in 2 seconds or 3 seconds, I can have a look at the heart and globally evaluate the heart by this strategy. Ultrasound is essential, and I read one of the very recent articles about using ultrasound for refinement of needling of the fistula, even for fistula, for localization, for difficult cannulation, for assessing maturation, for IVC, lung ultrasound. This means that there is a very nice article under the name the nephrology as ultrasonographer. We should learn and be trained on using ultrasound every minute. And for intervention nephrology, also, this is an area of unmet needs here, because we are governed, as you are governed, by the organization. In every center, there is rules. Here we depend upon the intervention radiology. In other places, nephrologists do everything. But I think the stream should move toward encouraging intervention nephrology. Thank you, Dr. Yasser. If you have any comments, I'll be happy.
I fully agree with you, but just one point to add, probably
Yes.
Professor Riyad and Professor Faissal Shaheen will love on this, is that every nephrologist here, as part of training, they must know how to use echo to measure the IVC diameter and the change with inspiration to assess the fluid status. The reason for which I'm saying my great professors will love on this is that they used to assess in the old clinical way rather than using an echo in order to measure the IVC and diameter. Otherwise, I fully agree with you. And I just want to say the UK Kidney Week is running virtually, but I did withdraw myself from that in order to attend this because I know it's more useful. Thank you so much.
We have at our hemodialysis unit here at Urology and Nephrology Center a hot and active program for training all residents to use ultrasound to measure the dimensions of inferior vena cava and the pulsatility index. So this is one of the clinical activity. We don't consider ultrasound as an investigatory tool. It is complementary clinical examination tool. So this is what we incorporated, and we are moving forward toward even permacath and others, but step by step, because we are governed and restricted by the organization as you have. Thank you very much. Yes, thank you very much. Dr. Saeed Khamis, your comments, please, Dr. Saeed.
Thank you, Professor Hussein. Thanks, Professor Dr. Ahmed, for this elegant presentation. I would like to have a comment, Dr. Hussein, regarding we should talk the same language when we refer the patient to the vascular surgeon because of access problem. Unfortunately, especially from the junior colleagues, they refer the patient to say end-stage access failure. And this is a premature decision or premature diagnosis. When the upper limb and the lower limb are exhausted, it doesn't mean that it is in end-stage access failure. And I remember I read one article maybe 2-3 years back, published in American Journal of Kidney Disease, as I remember, classified this nomenclature into grade 1, that means exhausted both upper limb, grade 2, both lower limb, grade 3, other alternatives or other options. So still, even the upper limbs and the lower limbs are exhausted, still there is translumbar, transhepatic, and vena cava. So we should not tell that prematurely end-stage access failure, except after we exhaust all options of the access. Thank you so much.
Thank you very much.